Welcome to the debate. Today, we're diving deep into a really fundamental methodological question in epidemiology. How do we choose the best approach, the optimal way to study the links between diseases and exposures, to get the most robust and informative insights? The central question we'll be wrestling with today is this. When investigating the association between an exposure and a health outcome, which study design, cross-sectional or cohort, offers the most robust and informative insights? I'll be arguing pretty strongly for the distinct advantages of cohort studies, really emphasizing their unique strength, especially when our goal is figuring out causality.
And I fully acknowledge the theoretical power of cohort studies. Absolutely. But I'll be highlighting the indispensable practical utility and specific strengths of cross-sectional studies. They play a really vital and I think often underestimated role for certain research goals in the real world, even as we, recognize the inherent limitations that both designs definitely have.
Right. So when we talk about establishing strong etiologic associations, really understanding the causes of disease and trying to piece together the natural history, how a disease develops over time. Cohort studies are, in my view, they're kind of the gold standard. Their fundamental design is built around observing the exposure before any disease actually starts. And think about the significance of that, right? It's absolutely critical if you want to infer causality. Our foundational texts emphasize this makes it, pretty straightforward to establish that crucial temporal relationship. It's not just some theoretical nice-to-have. It directly addresses that classic chicken and egg problem. Did the exposure genuinely happen before the outcome? Without that temporal clarity, any causal claim is, it's on shaky ground. Furthermore, cohort studies let us directly calculate the incidence of disease. We can see how often the disease pops up in both the exposed group and the unexposed group. This isn't trivial. It's the bedrock for them directly calculating the relative risk. And this gives us a clear quantitative measure. It tells us, with precision, exactly how much more likely an exposed person is to get the disease compared to someone who wasn't exposed. That kind of definitive, quantifiable evidence is just invaluable for public health interventions. They're also particularly well-suited when the exposure itself is rare. We can efficiently find groups already exposed to something uncommon, like, say, a specific industrial chemical, and then just follow them. And crucially, prospective cohort studies minimize recall bias.
Because you collect exposure information right at the beginning, before anyone has developed the disease, there's far less chance that their memory of past exposures is colored by their current health status.
Okay, I absolutely concede the theoretical elegance and the directness of that risk calculation you get with cohort studies, especially when it comes to, teasing out temporality. They are indeed powerful tools. However, we just cannot overlook the absolutely indispensable role of cross-sectional studies, particularly as that initial pragmatic first step in the broader research process. These studies are often the essential groundwork for developing hypotheses in the first place. They give us a snapshot of a population at one single point in time, providing quick and, importantly, relatively inexpensive insights into the existing disease and exposure prevalence. This isn't about nailing down deep causal inference right away, but about building that foundational understanding. Right. And from a public health planning perspective, these studies are vital. They help us identify prevalent, meaning existing cases, and that's critical for figuring out the current extent of disease in a community, and crucially for planning health services and, deciding where facilities are needed. Think about tracking the prevalence of self-reported obesity across different states. That kind of data is immediately actionable for allocating resources and for targeting public health campaigns effectively. Cross-sectional data even has these practical uses in just improving data quality. It can be used to validate and sometimes correct errors in things like self-reported weight and height. Now, while cohort studies are powerful, let's be honest, they aren't without their pretty significant practical hurdles. They usually need very large populations, which makes them incredibly expensive. You're following thousands, sometimes tens of thousands of people over long periods. And they often become impractical when the disease you're studying is genuinely rare, because you just need an astronomical sample size to observe enough cases to say anything meaningful. That long follow-up period itself can be a huge practical barrier, both financially and logistically.
Your points about practicality and their utility for that early stage hypothesis generation are well taken. And I do agree cross-sectional studies fill that descriptive niche effectively. However, my fundamental concern really remains their ability to definitively establish temporality. If our ultimate goal is to understand causation, then the inability of cross-sectional studies to really tell you if the exposure came before the disease, well, that's a profound weakness. As our source material explicitly states, it's often impossible to establish that temporal relationship. And this limitation leaves us vulnerable to what we call reverse causality. An observed association might mistakenly lead us to think the disease caused the exposure, or maybe that both are just influenced by some other factor we haven't even measured. For instance, an association found between, say, exercise levels and heart disease in a snapshot study might actually reflect survival after having coronary heart disease rather than the actual risk of developing it in the first place. You see, people who survive a heart attack might then, quite reasonably, adopt healthier lifestyles. Without knowing the timing, you just can't untangle that. And this inherent ambiguity severely limits their use for making really robust causal inferences.
I absolutely agree that the temporal challenge is a key limitation for cross-sectional studies if the singular goal is direct, unequivocal, causal inference. Fair enough. But let's be clear. These studies aren't primarily designed for that specific purpose. Their strength truly lies in providing those crucial initial observations, as the text says, and identifying patterns that warrant further, more resource-intensive investigation down the line. They give us essential prevalence data, like, for instance, the percentage of neuroblastoma cases under 1 year old in specific regions like Sapporo and Hokkaido, Japan. This is crucial information for informing where we focus our precious resources and for guiding those subsequent more complex studies, maybe even leading to a cohort study eventually. It's really about building the foundational layers of our understanding.
Okay.
And, let's not paint cohort studies as completely flawless either. Despite their robust design, they are far from immune to potential biases themselves. Consider loss to follow-up, for example. If a significant chunk of your participants drops out over that long study period, and importantly, if their reasons for dropping out are related to either their exposure or their outcome, well, that can significantly skew your results and complicate the accurate interpretation of those incidence rates you were talking about. So while cohort studies certainly aim for high rigor, they definitely grapple with their own set of mythological hurdles in practice. And this brings us squarely to the very real issue of resource constraints in epidemiological research. We often operate under significant real-world limitations: time, money, personnel, you name it. The relatively inexpensive nature and often smaller sample sizes needed for cross-sectional studies make them an incredibly pragmatic first step. This is especially true when you're just doing initial exploration, when we simply don't yet know enough to design a highly specific, long-term, expensive study. Or, as the text notes, when a tremendous number of people would have to be followed in a cohort study, particularly if we're investigating a truly rare disease. That long follow-up period and the substantial cost of cohort studies can just be prohibitive. They can delay or sometimes even prevent crucial research from ever getting off the ground, leaving pressing public health questions unanswered for years. Can we really afford to always wait for the quote-unquote perfect study when immediate insights, even imperfect ones, could potentially save lives?
That's a very valid point regarding the pressures of real-world resource constraints, and I certainly understand the appeal of a quicker, less expensive approach. I really do. However, I would argue that compromising on methodological rigor purely for the sake of practicality can unfortunately sometimes lead to misleading conclusions. And this isn't just an academic quibble, it can potentially misdirect public health efforts and, crucially, scarce resources down entirely the wrong path. I mean, think about the cost of implementing an ineffective intervention based on a flawed causal inference drawn from a less rigorous study.
Fair.
While the investment in a well-conducted cohort study is undeniably greater, both in terms of time and money, the evidence it yields is far more definitive. It directly measures incidence, as we discussed, and allows for those robust relative risk calculations, giving us a much clearer picture of the true risk involved.
This definitive evidence, as our core material emphasizes, is absolutely indispensable for formulating sound, evidence-based public health policy. And what's more, the long-term value of cohort studies is often tremendous because they allow us to examine multiple diseases potentially stemming from a single exposure, or even track multiple exposures and their various effects over time. The Framingham Heart Study, which has been running for decades now, is just a prime example of this. It's offered a breadth of insights that a single cross-sectional study simply cannot provide across time. It's an investment, I'd argue, not just an expense.
And just to further highlight a specific strength here, cohort studies are exceptionally well suited for studying rare exposures. Imagine trying to investigate a very specific occupational exposure, like a particular chemical used only in a niche industry, and its potential link to a rare type of cancer. It's far more efficient, logically, to identify that specific group of exposed workers and then follow them forward in time to see if the disease develops. Trying to do this the other way around, say with a case control approach, where you find cases of the rare cancer first and then try to retrospectively figure out if they had that equally rare past exposure, now, that becomes a logistical nightmare, potentially riddled with recall bias. This direct observation of the exposed group, followed through time, inherently provides much better data on the temporal relationship between exposure and outcome than other observational designs. It consistently moves us closer to drawing meaningful causal inferences.
Okay, I fully acknowledge that distinct advantage of cohort studies for rare exposures. That's a clear situation where their design truly shines, absolutely. However, let's consider the flip side. For exploring multiple possible etiologic factors for a given disease, especially if it's a rare disease, case control studies, which, as I mentioned, often emerge naturally as a follow-up to initial cross-sectional findings, often offer their own distinct advantages. In that scenario, you're starting with the disease and looking back at multiple potential exposures, which can be far more efficient than following a massive cohort hoping for enough cases of a rare disease to eventually emerge to study all those factors.
Interesting point.
And while cross-sectional studies may not establish causation directly, let's not forget they provide invaluable, actionable insights into prevalence and geographic distribution for immediate public health planning. Take, for example, plotting Lyme disease cases across the United States by county in a specific year. That kind of descriptive data, that snapshot of distribution, is absolutely critical for understanding the burden of disease right now, identifying hotspots, and deploying resources effectively. We might not yet know the precise causal chain just from looking at that map, but we know where to send our resources, where public education efforts are most needed, and maybe where to focus our next round of more targeted research. It's about effective public health management in the present moment.
So to summarize my position then, while I wholeheartedly agree that all study designs have their appropriate place in the hierarchy of evidence, for robustly addressing those critical questions of disease causation and establishing a clear, unambiguous temporal link between an exposure and an outcome, cohort studies, particularly the prospective ones, really stand as the preferred and most powerful approach. Their inherent ability to directly measure incidence and relative risk, coupled with their capacity to significantly minimize recall bias regarding exposure, provides the most scientifically rigorous and definitive insights we need for identifying strong ideologic associations. They represent, I think, the investment that pays the biggest dividends in causal understanding.
And I'll conclude by just reiterating the critical and frankly foundational role of cross-sectional studies within the broader epidemiological process. They serve as essential tools for that initial descriptive epidemiology, enabling crucial hypothesis generation and providing that indispensable understanding of current disease prevalence, which is vital for effective public health planning and resource allocation. While they fundamentally cannot establish temporality in the same way cohort studies aim to, their practicality, their speed, and their cost-effectiveness make them invaluable preliminary steps. They often illuminate the path forward and guide precisely where and how we should undertake those more resource-intensive investigations, like the powerful cohort studies we've been discussing. They are, in a way, the essential scouts for the deeper scientific expeditions.
Ultimately, I think it's clear from our discussion today, and indeed from the very fabric of the epidemiological principles laid out in our foundational texts, like Gordy's, that the choice of study design isn't really about one being universally superior or inferior across the board.
Precisely. Yeah, rather, it depends entirely on the specific research question being asked, the very real resources available to the investigators, and frankly, the stage of the scientific inquiry. Each design contributes uniquely and, I think, indispensably, adding its own piece to our overall comprehensive understanding of health and disease.